welcome to the debate. Today, we're diving into a really challenging area of medicine, those systemic symptoms that just don't fit into a classic allergy diagnosis. We're going to be focusing specifically on the growing recognition of something called histamine intolerance, or HIT. And the core tension here for both doctors and patients really boils down to this. Do we stick to the old playbook, a strict differential diagnosis, ruling things out one by one, maybe a supervised elimination diet? Or do we need to embrace a more personalized, holistic approach right away, using these new tools like gut microbiome analysis and IgG food panels to find the so-called root cause? I'm going to argue that this personalized root cause approach is not just helpful, it's essential.
And I'm going to be coming at this from a very different angle. While I absolutely acknowledge the suffering that comes with these chronic food reactions, we just can't afford to throw scientific rigor out the window. My position is that many of these newer diagnostic methods, especially things like IgG tests or relying too heavily on a single DAO level, they just aren't robust enough or scientifically validated for primetime clinical use. I think relying on them creates a huge risk of misdiagnosis and, maybe even worse, pushes patients into these incredibly severe and unnecessary dietary restrictions. So for me, it has to start with meticulous, evidence-based protocols.
Okay, but the evidence we have makes a really compelling case that these complex systemic problems, we're talking about things from chronic eczema to constant phlegm and congestion, even deep fatigue, are profoundly rooted in what's happening in the gut. We have measurable data that points to things like microbial imbalance or dysbiosis, increased intestinal permeability, what people call leaky gut, and of course a drop in diamine oxidase enzyme activity. And I have to push back on this idea that we should just wait. If we only treat the surface symptoms, say giving someone an antihistamine for a runny nose, we're papering over the real problem underneath. This is where precision becomes so vital. Using comprehensive testing, like a detailed gut microbiome analysis or these big IgG panels, lets us personalize the treatment. We can move beyond just saying avoid these foods. We could actually target the gut environment with specific probiotics or supplements like L-glutamine to help heal the gut lining, and even use strategies like intermittent fasting. That's how you get at the source of the histamine problem and create a real anti-inflammatory effect.
I see why that's so appealing. I do. The frustration is real. But let me offer a different perspective on that idea of precision. Histamine intolerance, as a standalone diagnosis, is still a very, very controversial idea in medicine. I mean, it's not even recognized as its own condition in the ICD-11, which is the global standard. So for me, the priority has to be evidence-based medicine, and that's exactly where this new wave of testing falls short. The actual efficacy of many of these tools, trying to draw a straight line from a single serum DAO level to a patient's symptoms, or using something like a hair strand test for food intolerance, the robust consensus-backed science just isn't there yet. I'm just not convinced by that line of reasoning, because you're using unvalidated tests for symptoms that are famously nonspecific: headaches, fatigue, stomach pain, and they overlap with so many proven conditions, like IBS or celiac disease.
You risk putting people on these extreme long-term diets. Diagnosis has to begin by meticulously ruling out the known diseases first.
Let's talk about what we can measure, though, because that moves this beyond just waiting for a stamp of approval from a committee. The source material gives us some powerful data connecting what we see in the gut to these systemic problems. So take eczema. A huge number, something like 80% of eczema patients show a significant imbalance in their gut flora. Now, when you have that kind of dysbiosis, you get bacterial byproducts, toxins, and that triggers a massive inflammatory response, a cytokine cascade, which then shows up as symptoms way outside the gut: fever, inflammation, that mucus production we talked about. It's a perfect illustration of the gut-lung or the gut-skin axis. And the thing is, we can detect these imbalances quantifiably, not just based on symptoms. A gut microbiome analysis can pinpoint a specific lack of, say, bifidobacterium or lactobacillus species that we know are crucial for keeping inflammation in check. That gives us an objective, non-invasive way to create a treatment. And then you have the IgG-based testing. if we just acknowledge that it's tracking a different kind of reaction, a delayed, chronic, non-IgE reaction that can take days to show up, then it gives us an invaluable piece of the puzzle about what's causing that low-grade, constant inflammation. That's something an immediate allergy skin prick test will always miss.
I understand the appeal, I really do. This idea of mapping the entire inflammatory picture. The problem is in the interpretation and, frankly, the actionability of these tests. When you talk about something like a hair strand test or even these broad IgG panels, the consensus from major allergy and gastroenterology groups is pretty clear. They are not reliable diagnostic tools. And why is that? It's because IgG antibodies are just a sign of exposure, not necessarily intolerance. I mean, pretty much everyone will have IgG antibodies to foods they eat all the time. Confusing that normal immune memory with a disease is, well, it's a fundamental diagnostic error. And honestly, the scientific basis for many of these novel tests is just weak when you compare it to what we already have. For celiac disease, we have serology and biopsy. For lactose intolerance, we have hydrogen breath tests. These are objective, they're reproducible. The idea that you can determine a food reaction from analyzing a strand of hair or from an IgG level just isn't backed by the kind of rigorous, controlled trials we need. We're in danger of turning a normal diet into a diagnosis. Okay, let's drill down on the main mechanism here, diamine oxidase, or DAO. Now, no one disputes that DAO is critical for breaking down histamine in the body. But this theory that low DAO is the primary cause of all these HIT symptoms, it gets really complicated by a lot of other factors. For one, that serum DAO measurement that's so often used, it has a pretty limited correlation with how a person actually handles histamine over the long term. It can be very transient. And why is it transient? Well, DAO activity is inhibited by a huge number of common things. We're talking about common drugs, antidepressants, some antibiotics, alcohol, and this is a big one, other biogenic amines. I'm talking about compounds like putrescine and cadaverine, which you find in aged cheeses, fermented foods, cured meats. They compete directly with histamine for that DAO enzyme. So this makes it incredibly difficult to say that a low DAO level is a fixed genetic root cause versus just a temporary effect of someone's diet or medication. It's a real oversimplification.
That's a compelling argument. And I agree, a single DAO snapshot taken in isolation can be misleading. But have you considered that DAO deficiency is very often secondary to a chronic disease in the gut, like untreated celiac, or IBD, or just widespread dysbiosis? These conditions physically damage the intestinal lining, which is the very factory where DAO is produced. So if you damage the factory, of course production is going to drop. So the beauty of a gut microbiome analysis is that it lets us look past that simple DAO number and see the structural damage and the inflammation that's causing the low DAO in the first place. The low DAO isn't the answer. It's a clue pointing to a deeper problem in the gut. And on top of that, the fact that we see in clinical settings that giving patients DAO supplements improves their symptoms, their skin, their breathing, their digestion, that strongly suggests its role is undeniable. So we have to find the reason for the deficit, whether it's genetics or gut damage. We can't just put a Band-Aid on it with antihistamines that completely ignore the core enzyme problem.
I'm sorry, but I just don't buy that our current diagnostic tools can make that separation robustly enough. Not yet. We have to be really clear with our definitions here. HIT is supposed to be a non-immune reaction. It's separate from a true, life-threatening IgE allergy, and it's also separate from scombroid poisoning, which is just a massive dose of histamine that would overwhelm anybody. But the critical problem is that the symptoms blamed on HIT, migraines, fatigue, gut pain, they're just so non-specific. They overlap with dozens of other conditions, including anxiety or IBS. And even the supposed gold standard test, a double-blind oral histamine challenge, is notoriously inconsistent. It can trigger symptoms even in healthy people. So with that much subjectivity and no consensus on an objective test, we risk telling patients to eliminate huge categories of very healthy food. And I mean, think about the nutrition here.
Or Bruce, we're talking about telling people to avoid tomatoes, spinach, aged cheese, fermented foods. These are major sources of antioxidants, iron, calcium, probiotics.
If a patient cuts all of that out because of a fuzzy IgG panel result, they could be heading for real nutrient deficiencies, all based on a diagnosis that isn't even supported by validated science. A careful, supervised elimination and reintroduction is still the safest, most evidence-based way to go.
I completely agree on the distinction. It's all about that individual threshold, which is lowered in HIT patients because their ability to break down histamine is compromised. And that is precisely why the personalized approach is better. It avoids those unnecessary restrictions you're worried about. We aren't just guessing, we're identifying a specific physiological reason for their symptoms. And to your point about nutrition, let's go back to the personalized interventions. When we use something like a gut microbiome analysis, we learn why the gut is inflamed, and then we treat that. Using strategies like intermittent fasting isn't just about avoiding histamine, it's about giving the gut a complete rest. That rest period lets the intestinal lining actually heal itself, which helps calm down the mast cells that release all that histamine. So by fixing the gut health, we actually raise the patient's threshold. We make them more tolerant to a wider variety of foods over time, which is the exact opposite of forcing them into long-term restriction. The goal is healing, not just avoidance. So to summarize my position, the path to really helping people with these systemic, non-allergic symptoms isn't about masking them. It's about identifying the underlying dysfunction, the state of their microbiome, the integrity of their gut lining, their enzyme activity, through comprehensive analysis. A personalized approach using targeted support like DAO enzymes or specific probiotics allows us to address the root cause, and that's what leads to real, lasting relief across all these different body systems.
And for my part, I think intellectual charity is key. We absolutely have to acknowledge the reality of these chronic symptoms and help these patients, but we can't do that by abandoning scientific rigor for what's new and shiny. For now, HIT has to remain a diagnosis of exclusion. Until we have objective, reproducible tests that are widely accepted, the most responsible path forward is a careful, physician-supervised differential diagnosis followed by a very structured, short-term elimination diet with a clear focus on preventing the harm that can come from unnecessary long-term nutritional restrictions.
And I think this debate really highlights that fundamental tension between a patient's desperate need for answers for these complex symptoms and the medical community's, its necessary reliance on science that is validated and reproducible.
Exactly. And it just underscores that we still need a significant amount of critical research to refine our diagnostic methods before any of these unproven approaches can or should become the standard of care.